palliative care, physician and Department of Nephrology in St. George Hospital, Sydney, Australia. And he's also a senior lecturer, University of New South Wales. I have, whichever textbook or articles that you read about renal palliative care, you can see Frank Brennan's name there. That's how I started knowing about him. And recently we met during the conference, and he was so kind. He didn't think twice. He agreed when I asked, can we start a series on renal palliative care? And that was a very nice gesture from you, Frank. Thank you so much for agreeing to be a part of this program. We have around 100 plus participants registered for today's webinar, and that is very promising because people want to learn about it. That's what I take it from the 100 plus registrations today. Thank you so much, and over to you.
Right. Thank you so much for that lovely introduction. I'm just going to, this will stop, yes. Just going to see if I can get this up on the screen. Okay, so I better just double check that everyone can see that screen.
Yes, we can.
Good. And I'll just check whether it moves through to the next slide,
Yes, it is.
Oh, well done. That's lovely. So look, it's lovely to be with you all. This is and congratulations to all the organisers of everything there at Pallium India. You're such a remarkable group over many years. And your international reputation is very, very high. And I'm delighted that there's a move towards looking at palliative care in the non-malignant setting, because there's certainly a lot more work being done in that. Bringing palliative care principles that you've all learnt about into a non-malignant domain. So today I'm going to speak, and in this series, going to speak about kidney supportive care, an alliance between nephrology and palliative care. The overarching theme of this series is symptom management. But before jumping into symptom management, this lecture is going to give you an overview of what kidney supportive care is. But I will start with a symptom case because it's very illustrative. Some years ago, I was asked to see in rural New South Wales a 53-year-old Aboriginal woman, type 2 diabetes mellitus, hypertension. She had diabetic nephropathy and she'd been on hemodialysis for about 5 years. When I was told she was coming, they said this woman is near suicidal with her symptoms. She shuffled into the clinic room, her head was down, there was no eye contact. When I started to get her to talk, she described how my legs move all through the night. She had severe uremic restless leg syndrome. I itch all the time. Often it becomes ferocious. And note the language there, that extraordinary word, ferocious. She had very severe uremic pruritus. My feet and calves burn and get pins and needles. It is awful. She had severe diabetic peripheral neuropathy. And sleep, I asked her. I don't sleep. I doze in 5-minute lots. I sit on a chair and put my elbows on my knees to hold them still, and I pray to die. In palliative care, we see many, many patients who are suffering, but this patient was the image of suffering. What could we possibly do for her? And I'll return to this particular woman and what we were able to do for her later into the second and third lectures. So in terms of just an overview of what I'm going to speak about today, I guess we need to establish, why would palliative care and nephrology sit together? Why would nephrology benefit from palliative care? In other words, the interface of the two disciplines. This was really important when we started this area, because for some nephrologists is, why would we need another discipline? What is this palliative care? Why would that help our patients? I'm going to briefly speak about decision-making around dialysis. I'm going to turn to this topic of the conservative management of kidney failure, and certainly make reference to many, many places in the world where there's limited access to dialysis, that people are on a conservative pathway, not because of choice, but because of circumstance. They simply cannot afford dialysis, or it's not available. The subject of this series is symptom management. I'll briefly touch on advanced care planning in nephrology, and care of the dying patient I'll briefly speak about. So hopefully this lecture sets the scene for the following lectures in terms of symptomatology, but it's very good, I think, to get an overarching perspective on what is kidney supportive care. I'll also turn to developments in India and internationally. So let's talk about this. What are the interfaces of nephrology and palliative care? Some of you may or may not have seen me give talks before, but I often use this painting, a very beautiful painting, and it's really a metaphor. This is from the desert areas in Australia. When European settlers first came into this area, they saw this as God-forsaken desert country of no value at all. But it was only into the 20th century when great artists like this artist, Albert Namatjira, a great Aboriginal artist, people started to look at this landscape with the eye of beauty. So we can look upon the landscape of a patient with life-limiting illnesses with two eyes at the same time. We can look upon them, of course, with if they've got cancer, chemotherapy, radiotherapy, surgery. If they've got kidney disease, dialysis, transplant potentially. But we can also look upon them with a palliative eye in terms of symptom management, good communication, advanced care planning, care of the dying, all those important things. So looking upon the landscape of our patients with two eyes at the same time, not necessarily waiting until they are dying. So what is the interface of these two disciplines? I would say it's 5 separate stories: epidemiology, mortality, morbidity, quality of life, and quality of dying. Epidemiology. Well, at the beginning, when dialysis was first invented, it was seen, and still is, a miraculous technology, but it was very limited access. It was really reserved for younger, fitter patients. And it was only as some years went by that Western developed countries started to make dialysis more available, that things started to change. In developed nations, the mean age of patients commencing renal replacement therapy being hemodialysis, peritoneal dialysis, or transplantation, is 60 to 65. And the age cohort that's greatest prevalence on dialysis is the 65 to 84-year-old age group. So more and more we're seeing in the literature this expression, geriatric nephrology, and all the geriatric syndromes that come with patients at this age. The other aspect of change is the rise of diabetes mellitus. So the percentage of incident patients with end-stage renal disease that have diabetic nephropathy is starting to grow hugely, greater than 50% in some countries, 40 to 50% in some countries. In 1 or 2 countries, it's almost 2/3 of those starting on dialysis have diabetic nephropathy. And when you think about all the other macro and microvascular complications of diabetes, this is a significant story, isn't it? Globally, some nations have resources that allow the possibility of everyone, even including older, frailer patients, being put on dialysis. So that's some nations. Other nations have more limited resources, and dialysis is reserved for younger, fitter patients, or simply reserved for those that can afford dialysis. And then other nations where there's poor resources and dialysis is simply not available. Throughout the world, therefore, many patients with kidney failure embark on a conservative non-dialysis pathway, not through choice, but simply because dialysis or transplant is not available or affordable. So this is becoming quite a topic within nephrology in the last couple of years. What is the role of nephrologists and indeed kidney supportive care for these patients in these circumstances? In India, it's estimated that 7% of the adult population has chronic kidney disease. Now, that could be all levels, of course. So from stage 1, which is very mild, stage 5 is an eGFR under 15 mils per minute. And that's also described as stage 5, chronic end-stage kidney disease or kidney failure. Now, this is very interesting. 2013, one of the leading nephrologists in India wrote this article where he talked about end-stage renal disease and made reference to this. According to data from large hospitals, end-stage kidney disease patients primarily attend for diagnosis and receive hemodialysis for only a brief period. It is estimated that most of them discontinue dialysis and die. Gradually, however, patients are being maintained on hemodialysis in increasing numbers. So that's 10 years ago. But in the last couple of years, there's been a remarkable national dialysis program that's being unfolded. Pradhan Mantri National Dialysis Program, an attempt to make dialysis in India much more available. The challenges have been, of course, manpower in terms of nephrologists, dialysis nurses, let alone the discussion about kidney supportive care. So this is quite a story that's unfolding. Okay, so we've talked about epidemiology. Let's talk about mortality. One of the myths is that if you start my father on dialysis, he will have a normal life expectancy. Unfortunately, no. So overall, patients with kidney failure, whether or not they're receiving renal replacement therapy, have a reduced life expectancy. In Australia, if you're 65 to 74, the annual mortality is 11%. But if you're 75 and above, that figure is 20 to 25%. Now, those figures are starting to look like the mortality figures of metastatic malignancy, aren't they? Symptomatology, well, this is the topic of this series, and this is a group that are very symptomatic, and we'll talk in much more detail about that. Quality of life. Well, we do know quality of life studies have been done around the world, and it shows that dialysis patients have a reduced quality of life compared to those who are not on dialysis, and it's particularly in the physical domains. This is drawn from our local work where we use the SF36. The top line, the black line, is age-related normals who are not got kidney failure, and the bottom line are dialysis patients. And as you can see, the physical, so on the left side of the screen are the physical domains of quality of life. On the right-hand side are mental health domains. And as you can see, the physical domains are significantly reduced and pretty consistently over all those years, less so the mental health domains. Quality of dying, well, in palliative care, we understand what I mean by that. How does a patient die, in what circumstances? So this can vary hugely in kidney disease. It can be a patient has died having been on dialysis or never having been on dialysis. It can be because of cardiac disease or their underlying renal disease or malignancy. So lots of different reasons. It's potentially that they've been on dialysis and they're withdrawn from dialysis. So the circumstances can vary considerably. If it's expected death after withdrawal, the management of the dying phase is crucial. And the manner of that dying will be remembered forever by the family. Indeed, that statement could be said about every dying patient, of course. So if you were to ask me why palliative care and nephrology have combined, why they've connected, it's these reasons: epidemiology, mortality, morbidity, particularly symptomatology, quality of life, and quality of dying. That slide could also be used for things like cardiac supportive care, respiratory, neuropalliative care, lots of different flexibility, if you like, in terms of what palliative care is able to provide in terms of end-stage disease. So the recognition of this interface has over time led to the development of a discipline, if you like, called kidney supportive care. But what does it actually mean? Well, what it is the holistic multidisciplinary care of people with chronic kidney disease, especially chronic kidney failure, whether they are receiving kidney replacement therapy or being managed conservatively. So this is interesting. So it's very broad. One of the myths about kidney supportive care, it's only those who are on non-dialysis pathway. No, it will also include the dialysis patient, particularly the symptomatic dialysis patient, as you saw with that first case, and transplant patients, all comers with kidney failure. And it's holistic and multidisciplinary. Here you're starting to see the clear influence of palliative care in this domain. So also, kidney supportive care should not be seen as an excuse for governments not providing access to dialysis. For a government to say, you're developing kidney supportive care, we don't need to really give people dialysis anymore, or keep improving dialysis access. No, it's not. Governments still have that responsibility. So kidney supportive care is for the right patient at the right time, and that could be in all contexts. but it certainly doesn't mean that we have to abandon or excuse lack of dialysis access. So this discipline started to be brought together in a major conference some years ago. And collegiate controversies conferences are held by nephrology, looking at things like blood pressure management, calcium phosphate. But here they looked at kidney supportive care or renal supportive care. And in that particular gathering, there were representatives from India and many nations around the world. So it was a very fascinating discussion about how renal supportive care could be applied. Then in 2018, the International Society of Nephrology hosted a summit on what they called integrated kidney care, and this endorsed the role of renal supportive care. Isn't this fascinating? This is not palliative care knocking on the door saying, I think you should do this. This is from within nephrology. They're saying kidney supportive or renal supportive care should be starting to be adopted. And they went further and said should be seen as equal to dialysis, transplantation, all aspects of kidney care. The International Society of Nephrology now has a kidney supportive care working group looking on three things: an international definition of kidney supportive care, an international curriculum, which will be very fascinating to see, and that's drawing a lot from middle and lower income nations, and also creating and nurturing a kidney supportive care services around the world. So let's talk about this decision-making around dialysis. As I said, kidney failure, eGFR less than 15, until recently known as end-stage kidney disease. Well, look, once kidney failure is diagnosed, it's important to examine the various options. Essentially, it's two choices. One is to launch down renal replacement therapy, dialysis, transplantation, or to manage the person conservatively. So what are the important elements in this decision-making around dialysis? So this is the story really in a context where dialysis is available for you to be able to use. And I'll turn to the situation where dialysis is barely available and what happens with conservative care soon. But in terms of then working out by a nephrologist, working out whether this particular patient might benefit from dialysis rather than putting everyone on dialysis, and that's the big change in the modern era, is looking at things, well, is this person going to survive longer? Quality of life, hospitalizations, and effects on carers. Survivorship. So this is a major study back in 2007. So as you can see from the title, it's looking at patients who had kidney disease who were 75 and above, and what happened to them. Some of whom chose dialysis, some of whom chose a conservative pathway. This wasn't randomized. The clinicians just followed them through. Note the first author, Fliss Murtagh. She is a palliative care physician from the United Kingdom who did her PhD on this topic and has been the leading light in kidney supportive care around the world. So as you can see, what Murtagh and her group found was that those who were on dialysis had a clear survivorship, as you can see there. However, if you factored in comorbidities, particularly ischemic heart disease, those Kaplan-Meier curves started to collapse. So this started to give a clue. Maybe there is a group now that 75 and above, ischemic heart disease, that may not necessarily survive longer on dialysis than versus non-dialysis. So this was a major study. This study was repeated many times over and with identical methodology and pretty well identical results. So I think this has consistently been found. This particular study, the Chandra study, looked at older patients with low comorbidities and high comorbidities. And as you can see, with high comorbidities, that survivorship curve crossed. And also Carson did an interesting study, and their group, they said, okay, you older patients who are lasting longer on dialysis, how are you spending your extra time of your survivorship? And they found that about 80% of the extra days survived were spending on dialysis or being hospitalised for complications of dialysis. So this was an interesting thing. Yes, these patients are lasting longer, right, greater survivorship, but they are the dialysis patient and all that comes with that. This was a very major, influential study looking at dialysis in frail, elderly nursing home patients in the United States from the New England Journal. And as you can imagine, the story there. So before we get to the graph, just look at the figures there. This was a very comorbid group, 2/3 with diabetes, 2/3 with congestive cardiac failure. And also, interestingly, 22% with dementia. So that got a whole discussion going in the United States. Why are we putting demented patients on dialysis? It's another life-limiting illness, and eventually this person is not going to want to sit on a dialysis chair. They'll be wanting to take off their needles, and there'll be major behavioural issues. But look how poorly that group went. By 12 months, almost 2/3 of that patient group had died, and the remaining, their performance status had fallen off completely. So this was a huge story here for elderly nursing home, frail nursing home patients, people thinking, we need to be careful that we shouldn't be putting everyone on dialysis. The first of the studies like this was done in the Southern Hemisphere, was done in our centre at St George, and we found 75 with 2 or more comorbidities, one of which was ischemic heart disease and CCF. There was no survivorship advantage with dialysis versus non. This is an interesting study from Holland, which showed that survival advantage was lost at 80 years old, irrespective of your comorbidities, simply the age. Now, that's only 1 or 2 studies have shown that, and more studies need to be done, but that's interesting, isn't it? Quality of life, we've talked about there, in terms of perhaps the difference between dialysis versus non-dialysis. As you can see, as those graphs showed, dialysis group have a poor quality of life fairly consistently, but perhaps not so much there for the conservative in certain areas, general health perceptions, vitality, etc., mental health. What about hospitalisations, dialysis versus non? Well, in the elderly patients, the dialysis patients, they have 20 to 35 days per year mean hospitalisation time. Those in a conservative pathway have less. And part of the story is that they're not on dialysis, so they're not having to deal with the complications of dialysis. What about impact of carers? Well, this is a major story in terms of dialysis. So a huge amount of carer burden for these patients, and also the quality of life of those carers, increasing carer burden, and that increases with the patient's age and comorbidities, and worsening functional status and quality of life. So in terms of then guiding nephrologists around the world, what guidelines do exist when a nephrologist is sitting with the patient, whether to place the patient on dialysis or not? So this was a major document that came out of the United States, and I'll let you read the title because it's all in the title. And they had a couple of recommendations. It is reasonable to consider foregoing, in other words, not starting or stopping dialysis, where the patient has got a very poor prognosis or for whom dialysis cannot be provided safely. Note the language. It's not saying you shall not start the person on dialysis. It's just saying, think. It is reasonable to consider whether this is the right thing to start dialysis. And they talked about various situations where the medical condition precluded the technical process. Yes, that second one is very important, where every time you put the patient on dialysis, they get hypotension. Well, it may be unsustainable. And also where the person is simply not able to cooperate with advanced dementia. This is an interesting story where the patient has kidney failure, they're on dialysis, but now they've got metastatic malignancy. What do we do? So in our experience, patients don't stop immediately their dialysis. They'll keep going until the anorexia, cachexia, fatigue of their dialysis is such that they're ready to cease. But perhaps this is the most important part of those guidelines. They said, reasonable to consider foregoing dialysis in patients over 75, stage 5 CKD, who meet 2 or more of the following statistically significant poor prognostic criteria. Number 1, the surprise question, where the clinician thinks this person is unlikely to survive more than 12 months. High comorbidity score, particularly ischemic heart disease. Poor functional status and severe malnutrition, as evidenced by Alderman consistently under 25. So it's not just age, it's these other factors. And this has started to guide nephrologists around the world when they're sitting, particularly with the older group, perhaps to say, look, I don't think you're going to get an advantage being on dialysis, and I think that it will be okay for you to be on a conservative pathway. Many patients of that advanced stage, particularly the very advanced stage, can be very relieved to hear that. Oh, I'm so happy to hear that because I never really wanted to be on a machine. And I know that I'm going to die soon. It's okay. I don't need to have all this thing done. So it can be, it's not always that the patient is insisting. Sometimes families can be troubled by this discussion, but I think the evidence is clear that it's becoming more obvious that there is a cohort of older, frailer, highly comorbid patients who actually don't get an advantage. And once that's explained to family members start to say, well, okay, if it's not going to give you a longer survivorship, maybe why should we do it? Okay, we now need to turn to the conservative non. Now, why is this important? This is extremely important around the world because there are many, many countries that don't have complete access to dialysis. So this is a very important story, isn't it? So this may be decided in consultation with a nephrologist, as in those previous slides, the discussion about prognosis. Or the patient was never referred to a nephrologist in the first place, undiagnosed kidney failure. So the person just goes on and on and on, and no one has diagnosed it, and now they're in a pre-terminal or terminal state. And also the situation where it's diagnosed, but the patient was unable to have dialysis due to issues of accessibility and or affordability. So this is a very big story around the world. So what level of care occurs for this group, or what level of care should occur for this group? If it's being raised as an option, what does conservative care mean? What's, if you like, in the bowl of conservative care? What does it look like? Well, inside that bowl, there's no dialysis. That's true. But what else is there? What else is possibly present in a conservative management? And can we make predictions about their course? The challenge is to ensure that this pathway is not seen as second best or inadequate, but is thorough, systematic, and evidence-based. First of all, we just need to make sure that people don't feel abandoned, and that's why we need to have a coherent kidney supportive care services and a clear sense of the role of nephrologists for these patients. And not simply sending everyone through to palliative care, because as everyone online knows, there's so few of us. We're so busy that we can't be deluged. It would not be right. And so our model is not to send everyone through directly to palliative care, but to have kidney supportive care services within renal departments dealing with things. And sure, yes, once the person is now deteriorating and dying, absolutely getting palliative care. Now, that's one model. But I think it's very important for those patients, not simply for the nephrologist to abandon them and say, well, you just have to go off to palliative care. Why? Because those patients still need the skills of a renal physician. So if dialysis is not being offered, what does conservative care look like? I would say it's the best of our two disciplines. First of all, renal medicine, preserving residual renal function. That's very important. Monitoring and treating blood pressure, calcium phosphate, anemia. As you know, erythropoietin is produced by the kidney, and if it fails, then that's going to produce a deficit in anemia. Fluid balance. But also the combination there of the palliative approach, symptom management, advanced care planning, psychosocial support, and care of the dying patient. So what we're doing now with our renal trainees is we're starting to train them in both these lists so they can be as talented as diagnosing IgA nephropathy, dealing with anemia, etc., as they are with the care of the dying and the management of uremic pruritus, etc. So that's the challenge, to upskill nephrologists and indeed, realistically, in situations where there's not enough nephrologists around, palliative care physicians and primary physicians. That's, I think, where the future lies, in upskilling everyone in these skills. But it does require nephrology expertise to teach us about these things. So there's a modest but growing body of literature of research on this cohort of patients. In terms of survivorship, I'll turn to what we found. From a mean age of eGFR of 16, the median survivorship of conservative pathway was about 16 months. Now, this was much longer than we all thought. We thought, oh, gee, eGFR 9, 8, 7, surely the person is going to die soon. But in fact, people can be fairly resilient and continue on even with lower eGFRs. 1/3 of those patients lived more than 12 months after the eGFR fell below 10 mils. So this is an interesting story because these people are not on dialysis. They're living their lives. Many of them are able to do many, many things with their lives. Obviously, it's very important to treat their symptoms and support them. And so there's a whole series of other studies giving similar time there. What are their needs? Well, this is another Murtaugh study, and she followed a group of, note the mean age of 81 years. So this is quite an older group. And she followed what happened on a conservative pathway in terms of symptoms, palliative care needs, and functional status. So she found that the conservative group had a Konoski between 60 and 70 for quite a long time. And then about 2 months before they died, they took to their chair, they took to their bed, and their performance status started to fall off. Similarly, in terms of the global distress index, symptomatology, an increase there in the last 2 months. And also palliative needs and palliative outcomes scale. You can start to see the increase there at about 2 months. So this is very useful in terms of if you were to be constructing a kidney supportive care service, that they would be caring for patients really leading up to that point. And then when the person is deteriorating and it's clear that they're heading towards dying, then palliative care, the mainstream or community palliative care could be involved. But that's just one idea, because it has to be flexible, and we have to listen to what's actually happening on the ground. Symptom management. Well, that's the subject of the remaining lectures in this series. So I'm not going to speak more about that, but just to know that symptomatology is an extremely important aspect of this story. Advanced care planning, well, we've talked about that. That we can talk about that briefly. So this is the story of, well, you know exactly what advanced care planning is, but what does it look like in nephrology? Well, first of all, there's very little limited uptake, but certainly we've got a group that are really and can be really struggling with their health. It potentially might be that they deteriorate quickly. So I think that it would be right to start to look towards advanced care planning. And within nephrology, there's more and more of a move to try and get more advanced care planning done. And this is an interesting story, and I'd be interested to know in terms of how things go in terms of things in India, but just the cultural acceptance of advanced care planning, how that unfolds. So just a random case study, 52-year-old man, diabetic nephropathy, been on dialysis for 2 years, sudden collapse at home, significant CVA, barely rousable when he comes to hospital. But he's not able to make his decisions, and dialysis is due today. What are we going to do? So the family conference is called. The nephrologist recommends ceasing dialysis. The family is divided as to whether to continue with dialysis. Some say yes, some say no. During these discussions, the following occurs. Does your father have an advanced care planning? No. Did he ever talk about what would happen if he became very sick? No, in our family, we do not talk about these things. But doctor, did you ever talk to him about? No, we never got around to it. So this is a story where it would be very good to have the voice of that person here at the table, the advanced care planning discussion, to help everyone guide them through. So it's important, given the frailty, the kidney failure, and other diseases such as diabetes, there will be an increasing cohort of patients that at some point may well need an advanced care planning. Care of the dying patient, I'm not going to spend too much time on this because you would be experts in caring for dying patients. But just to be aware, as I said earlier, that it can come in lots of different guises. It can be a situation where the person's never been on dialysis and a deterioration of a conservatively managed patient. A patient who's on dialysis who may die suddenly, usually a cardiac death. But imagine if that's happening on a dialysis centre where everyone else, the person might have a cardiac arrest and die there. Well, everyone's going to know about that, and that's going to affect other patients and families and indeed staff. It could be that the patient is withdrawn from dialysis. So there's two cohorts here. If you're completely anuric, your median survivorship is about 7 to 10 days. But if you're still passing urine, you may surprise everyone and go on for weeks or even months. So just to be aware of those two stories. In terms of the kidney story, one of the myths is that when I started in this area, I was told, oh, a uremic death is a very gentle death. Well, it may or may not be. And certainly with uremic toxins building up, you may well get, in addition to more and more fatigue, you may well get uremic jerks and also potentially seizures, not so common, but it could happen, and confusion. You may well get itch that starts to develop more, restless legs, nausea, anorexia. Lots of different things can come here, which are perhaps different to a cancer patient. And we can talk about that a bit later. So if you were to ask me what's the recommended reading and developments in India, I would say that particular document would be a very good document to read, really giving you even though it goes back some years, I think it's got really all the leading lights in kidney supportive care have written that. I would then go to the Harris paper that's more up to date, and that talks about the whole of integrated kidney care, but it also talks about the renal supportive care, and indeed does quote the WHO definition of palliative care. I'll let you read that. I'll just go to get the citation of that. Okay, so just in India, there's been a couple of things that have unfolded fairly rapidly. First of all, there was a masterclass in Manipal in 2019. The Indian Journal of Palliative Care had a supplement on kidney supportive care in May 2021, and I'd recommend that. Echo India Trust lecture series on kidney support of 2019 to palliative care medicine and nephrology clinicians. And now, currently, there's another ECHO series of virtual masterclasses on this topic, so-called Impact Nephro Care, and that's co-organised by the Indian Association of Palliative Care in the Indian Society of Nephrology. Many of you know Dr. Nandini Valath, who used to be in Mumbai and is now in Bangalore. She's one of the main organisers of this. So that would be another series of educational opportunities there. So in conclusion, the role of kidney supportive care starts with a mutual acknowledgement of need. Over the past years, there's been an emerging interest, research and engagement at the interface of these two disciplines, but much work needs to be done at all levels. The management of symptoms is an important part of kidney supportive care, and that will lead me directly into the next lectures. Thank you so much.
Dr. Sridevi, you're muted.
Sorry. So wonderful presentation. This has given an overview of the global scenario as well as what is happening in India, probably because many times people don't know there are training programs or research activities happening in our own country. So this might have given an overview about the global as well as the Indian picture. We were thinking we can take up a few questions in the chat. Participants, you may not be able to unmute, but please type your questions if you have any in the chat. As Frank mentioned, in the coming series, we'll be discussing about it towards the end of the session, where we will be going more in detail into the symptoms also. So there is first question, Frank. What is the role of fluids in end of life? I think this is specific to renal end-stage renal disease. Yes, for chronic kidney disease, what is the role of fluids in end of life care?
So this is a very interesting topic, isn't it? Because once the kidneys are failing, the risk of parenteral fluids is that you quickly get fluid overload. So we have to be very, very conscious of that. So that's very important. So normally in an end of life context, when the patient is dying, we're coming back to the most basic, trying to keep the mouth moist so that the patient is not feeling thirsty. I think that's the main thing. What can sometimes happen is that people maybe have undiagnosed kidney failure, or they're on so-called fluid restriction, but they're so thirsty and they're having very salty food and they're drinking quite a lot of fluid and they come in fluid overloaded. So that's quite the discussion there among nephrologists as to how to deal with that at that time. We don't, in a pre-terminal story, yes, that certainly can occur. And what they normally do is dialyze them more, but if they're not on a dialysis pathway, increase the diuretics to try and clear the amount of fluid and just impress upon the patient the importance of adherence to those restrictions. So that can be very, very difficult for patients to do that. So in a pre-terminal story, it may be then trying to deal with that with diuretics. In a coming towards the end of life, we avoid parenteral fluids because it could quickly cause fluid overload, and try and keep the patient their mouth as moist as possible.
Thank you, Frank. Next question is actually about pruritus. For someone who have asked that, we are getting into the details. So I'm glad that we chose the right topics for the symptom management sessions also. So the symptoms will be taken in detail in the coming series. So maybe we can take it up then. Yeah, so there is one question where they can get support in Delhi. Someone has answered already. Yes, can support will be able to help you. The number is available in the website or even in the Pallium India website. Can support contact details are available. So is there any palliative? Yes, please.
That's interesting. Someone's just put up, what was the end of the story? I'm glad that you asked that question because, yes, I will reveal the end of the story next time when we go through each of the symptoms that particular patient was experiencing. My goodness, what an extraordinary story, an awful story she was going through. But I will talk much more about that at the next session.
There is a question, is there a possibility for dialysis for symptom management like breathlessness?
Yeah, it's an interesting question. And the answer is yes. Maybe not always, but it certainly can be. So there can be situations where the person is so overwhelmed with symptoms that one technique, if you like, in addition to all the usual medications and other things we'll talk about in the next lectures, can be dialysis itself. I'm conscious when that's done that then the person's now on dialysis and the whole question about what's happening next starts to come up. The family may say, this is perfect. He's so much more comfortable. Keep him on dialysis. So it may be that it's going to be a more difficult story than coming off. Or the patient thinks that the only thing to deal with their symptoms is dialysis. Whereas in fact, as I'll speak about in the lectures, we're more confident in using medications to deal with so many of these symptoms. But you're right, the dealing with certain symptoms, and perhaps a good example might be something like intractable nausea or vomiting, where things are just so awful, or occasionally intractable pruritus, or some of these other symptoms where you may do that, but it's certainly not jumped at. It's certainly possible to do that. But then we'd have to have the broader conversation about this.
I think there is another question on oliguria during end-of-life care and furosemide. I think we'll be covering that in one of the upcoming sessions. What is the survival rate with kidney transplant? That's another.
Oh, great question. Look, it would vary a lot around the world in terms of the particular units and things. But look, I think now I'm not a transplant physician. I know that aspect of things, but it can be the mean survivorship can go on for many, many years, but the aspects that are going to determine that are often the underlying comorbidities, particularly diabetes. The age does come into it, so there can be cut-offs in terms of that. Cardiac disease also can make things very difficult. But if you were to, I'll just perhaps turn the question slightly to one angle here and say, what's the role of kidney supportive care in transplant patients? Does palliative care have a role? Now, in my naivety, when I started in this area, I thought, oh, the transplant patients are fine. They're good. They've got a transplant. They don't need to worry about anything. And yet I realised that there was a series of issues for them. First of all, symptoms. Now, it's not identical list to the patient on a dialysis or conservative pathway, but certainly they can be symptomatic. Next is the failing allograft, where their transplanted kidney is starting to fail, and potentially they're heading towards losing that kidney, potentially restarting dialysis or having another transplantation. The third issue is because they're on immunosuppressives, raging infections, really complex infections, and also malignancy. And this is a fascinating interface of traditional palliative care and transplant medicine, where they can get extremely aggressive squamous cell malignancies, what they call post-transplant lymphoproliferative disease, and they should be reaching out to us to try and deal with the symptomatology of that and balancing carefully the immunosuppressive medicines with this. And then, of course, the care of the dying patient. So I think that there's a role there. I think it's barely been examined or barely been touched. In Boston, there's a kidney supportive care team led by someone who's double trained in nephrology and PAL care, and she and her colleagues are working with transplant patients, which is a fantastic story, really.
That was a real eye-opener question, or your response, because in one of your slides you were mentioning the survival rate and what kind of survival they had. So what defines survival is something that we need to think, whether it is number of days that they live, or whether it is the quality of life, a number of hospitalizations probably.
And you're quite correct. It was perhaps predictable that doctors in that question were going to go straight to survivorship, because that's often how we're taught. But in the last couple of years, in the literature now, is more than survivorship in terms of dialysis or not. It's the quality of life, hospitalizations, carer stress, distance, getting back and forth to dialysis. So a much broader discussion is coming into play, not simply survivorship. Yes, and you're quite right by saying that. Yes, people can survive longer, potentially, but what's happening in that time, and the whole thing of the complications and all the rest of it. And so that certainly is discussed more and more. And this is a big shift from an earlier era, in particularly in Western countries, where people thought everyone should be placed on dialysis. Well, even the nephrologists were thinking, hang on, we need to be careful about the highly comorbid, the highly frail patient. Is that the right thing to do? And there was sort of an oh yes, but everyone's going to get a survivorship advantage. And then they realise with those studies, actually there is a group 75 and above plus that may not get that advantage.
I think another important learning from your last response was in kidney transplant. As you said, we think, okay, they are getting transplant, so the problem is sorted there. They are going to have a better tomorrow or happy days ahead. We just don't, or at least I have not thought about the transplant patients would need integration of palliative care. I think that's something that we need to start. We have not yet reached to dialysis patients in our country yet, but still that's something which was an eye-opener from your last response.
Yes. And one of the fascinating things about that particular group is the psychology of this and our discipline. Many of those patients have a singular focus on surviving, of either their own transplant or they might have another transplant. And so palliative care, my goodness, no, don't come anywhere near me, because my focus is continuing to live. So there can be a psychological issue. So as we do with all our patients, we explain what we're doing, and we're here for your comfort, and we're here to help with the transplant medicine team, etc. So I think that's probably going to be the way to go, rather than everyone being so fearful and just explaining our role.
There is a question on the scope of peritoneal dialysis in India as well as globally.
Yeah, this is a really interesting question, and it probably would require a nephrologist to answer this question. So people understand, of course, about hemodialysis. So peritoneal dialysis is, and probably people understand that as well, the nature of that. So it's a different form of dialysis, but it is dialysis. It can be set, both hemodialysis and peritoneal dialysis can be set up in a domestic situation, but it does require training of the patient and the relatives to be able to do this. So, and there may be certain criteria back and forth. It's interesting, in some countries, Thailand is a really interesting example. Thailand, a couple of years ago, in terms of the cost of dialysis, they declared a PD first policy. So there was a big focus on getting people on PD rather than hemodialysis. I'm not sure how that is all going because that's a whole national story. But yes, that is another story. So yes, so that those patients can also have the same stories, that the symptomatology, the deterioration, the care of the dying in a similar way, but they're having PD.
So the next question, I think you've answered it. The second part you have answered, like what about renal transplant rejection, palliative care in renal transplant rejection? I think it is not just in rejection, but even in when they are recommending transplant, I think that's where we should be there, even not just in rejection. The scope is much beyond that. And just gathering from the question, when would you, in your setting, when will you actually start having the first conversation to the patient? What is the time of entry of the palliative care team into the nephro team?
Yeah, look, it's a really good question. So there's probably a couple of key moments. Number one is symptoms. So what we do is we've liberated the referral basis. So it's not just nephrologists referring to kidney supportive care. We go to the dialysis nurses. So they're empowered to refer patients to us. Now, why? The reason is that patients can come to a nephrologist every 3 months. The doctor looks really busy. The patient says, oh, the doctor says your biochemistry, anemia, everything's perfect. You're doing really well. And then they go and then they come onto their dialysis session and the nurse is saying, yes, but did you talk about your itch, your restless leg? No, I saw the doctor was too busy. So the recognition was that nephrologists were not necessarily picking up on symptomatology, whereas renal nurses, the dialysis nurses definitely were. So yes, so that would be symptomatology. The struggling patient who may be quietly deteriorating. Now, that could be someone dementing on dialysis, but also patients who are starting to age and becoming much more frailer and the struggle of being on dialysis. There's that. Every single patient where the discussion between nephrologist and patient has ended up with a decision to have a conservative pathway. So that's fairly obvious because they're older, frailer, highly comorbid, so that's another source of referral. So I think in a local setting where you are, I think it'd be a matter of just sitting together, say with the nephrologists and the renal nurses and working out, okay, what do you think is going to be a good point of entry here? Now, you may say, well, we can't have every single patient coming to a clinic. That's true. But there may be situations where the needs are starting to escalate. Symptomatology, poorer quality of life, a clear decision for a conservative pathway. Okay, we do need to now meet this person because they're not going to be a dialysis patient, so we need to deal with that. In addition to the nephrologist, as I said, the two of the best of both of our disciplines, but they'd be sort of the sense of things. What also happened, which was interesting, our head of department of nephrology was worried about the quietly stoical patient who was not saying anything to anyone, who was yet getting a lot of symptomatology. So what we did is every 6 months we do a symptom census of everyone in the dialysis unit. And what was happening was that some patients were ticking terrible pain, that they hadn't told anyone, thinking it was sort of part of the normality. So that's the department made an automatic referral of all of those patients to the clinic.
Thank you so much. Just one more thought. I know what is your experience in children with kidney disease, chronic kidney disease? I mean, the referrals will be generally delayed when it comes to children. In any case, even if it is cancer or neurological illness, because children are not meant to die or deteriorate.
Yes.
So how do you work with children with chronic kidney disease?
So I, as an adult physician, I haven't done that. I have had some younger patients, but in terms of children, I'm very much aware of the role of pediatric nephrology and pediatric palliative care. So one of the discussions I'm starting to have is with those groups, really getting them to talk a bit more with each other and work out what is the role of things. But you're quite right. The domain of palliative care coming into that, where parents may say, no, we cannot have palliative care. This is too much. But just bringing those principles, the classic palliative care principles, into that domain, just like any pediatric palliative care person would do, just the concentration on those aspects. But you're quite right. That's really tough, isn't it? The potential deteriorating and death of a child, that is very, very tough. Yeah.
So that question arises from a personal experience of knowing a family with a child who has been undergoing dialysis for past 15 years with lot of symptoms, transplant rejection. Still, the conversation has not happened. Still, the nephrologists think that it can go on, and the parents
Yes.
are looking forward for the next set of
Yes.
transplant to come in, and all
Yes.
these things. It's been 15 years with a lot of symptom burden and
Yes.
psychological issues, but not even a single mention about supportive care.
Yes.
So that's a very personal experience.
Yes. But I think that story would be reproduced around the world. And it is very fascinating, isn't it? In such a patient where there's such a struggle to go on and on, that topic is not mentioned yet.
So I was about to take the last question, but then Dr. Punita has stuck me in the one very, very interesting question. So suppose you are taking a conservative pathway and you are taking care of the patient. What all should be monitoring regularly? It is just the symptoms, or do you need some biochemistry also?
Yes. So this is a very good question. So to me, I think the best what they're now calling conservative kidney management, or CKM, would involve, as I said, either continuing to see a nephrologist and having them doing their renal medicine story, or if it's impossible, if the nephrologists are not around, being, I suppose, learning how to do this. But yes, just in terms of basic things, I would, a couple of things. First of all, keeping an eye on their renal function, because that'll give you an indication of how quickly things are unfolding. Keeping an eye on their hemoglobin, because erythropoietin is produced and in the kidney, and if the kidney's failing, that's going to cause a story. So that can creep up on the patient, and suddenly the person's very anemic. So the use of erythropoietin supplementation, and the issue then in lower and middle income countries is the cost of that. Keeping an eye on calcium and phosphate, blood pressure, fluid status, those basic things. Now, I'm not a nephrologist, so I would be turning to the nephrologist to continue to see those patients. Or if they're not able to do that, say, okay, you'll need to broaden this skill set, the skill base, because these are really important things that as palliative care doctors, we don't know this. But in the palliative care domain, absolutely, each time I would see the patient, I would do a symptom inventory, and I'll talk to you about the instruments there. I would get a sense, as we do with palliative care, the sense of what's happening with that person, the quality of life. Now, I may not necessarily do formal testing. I mean, you could do that, but I think how that goes. I would just check if there's an advanced care plan made or not made, how people feel about that, and then of course the care of the dying. So it's a combination really of those two stories together that I think are going to be the best. The worst story is that the patient is just sent to PalCare with the assumption PalCare can do everything. Well, we can't do everything because we don't have the skills of nephrology. Or you just go back to your general practitioner or your family physician. Well, yes, but the family physician also may not have the full set of skills of both the disciplines of nephrology and palliative care. So I think that's an ongoing, actually a live conversation within nephrology around the world. What is the role of nephrology in conservative kidney management? Some nephrologists saying, no, that's all we do. We only do dialysis and transplantation. And others saying, well, probably we need to do more than that. You know, we probably need to have more responsibility here.
Thank you so much. So I'm ending with the last question. Someone has asked, what is the future of palliative care in nephrology? It's a very good
Really
question
interesting.
to end this session, I think.
Yes, no, it's a great question to end the session. Absolutely. Look, I think there's probably a couple of answers to that question. One is the international story unfolding and being driven from the International Society of Nephrology, developing a curricula that's going to be a possible education tool for everyone around the world would be marvellous. Then also encouraging renal trainees to get interested in this area so that they see this equal to all the other aspects of their renal training. That's really important. Then I think within palliative care, the sessions like this, so that with palliative care, we're curious about what's going on in this domain, recognising our great strengths in terms of influencing other disciplines, the whole thing of potentially being part of the formation and creation and nurturing of kidney supportive care services. Wouldn't that be wonderful? But it might be cardiac, it might be neuropalliative, it might be other areas as well. So I would recommend to everyone online to think, yes, you've developed a lot of skills in terms of cancer and palliative care, but there are other domains now where your skills could be equally applied, and it's a question of just seeing what interests you have and working out what is possible.
Thank you so much, Frank, for patiently answering all those questions. That was a very, enlightening talk. A lot of thoughts and ideas just flashing through the brain, actually. So, really looking forward for more sessions.